So I'd like to introduce you today to Cindy Manning. She is an Assistant Vice President of ARUP Laboratories with the responsibility of managing the University Hospital and Clinic's transfusion services and immunohematology reference laboratory, or IRL. Cindy has over 30 years of experience in laboratory management and over 40 years of experience in the clinical laboratory. She has been a member of the CLMA for many years, and at one point served as president of the Utah chapter. She is a member of the American Association of Blood Banks. Cindy received her bachelor's degree in biology from Capital University in Columbus, Ohio, and is certified by the American Society of Clinical Pathologists in Medical Technology. She is uniquely qualified to give this presentation because she is a registered nurse holding licenses in both Ohio and Utah. Her nursing experience has been in the areas of critical care, hospital nursing, and hospice care. She uses this knowledge to actively interact with nursing staff and is very active with nursing staff education and audits regarding patient identification and blood administration. So I'll now turn our time over to Cindy.
Thank you, Cherie. I'd like to start my talk by, and forgive me, reading a short story that we will discuss as I get into the presentation today. Excuse me. John Tyler is a 30-year-old businessman in the height of his career. He has two beautiful children, Alicia and Sam, and another baby on the way. His wife, Sarah, is very loving and volunteers at the local school weekly. About a week ago, while crossing the street near his office in the evening after a long business meeting, John was hit by a motor vehicle. The driver was driving while under the influence of drugs and/or alcohol, but the driver didn't stop. He fled the scene and left John lying in the street. John was rushed to the nearest hospital where he underwent surgeries for his multiple injuries. Initially, he was not expected to live, but he had actually fooled everyone. He made it through several hours of difficult surgery and now was expected to make an almost full recovery. One evening, while Sarah and the children were preparing to leave to go home from a visit at the hospital, John grabbed Sarah's hand, and with his other hand he grabbed his head. He looked at her with such a strange look. His color seemed to become very pale, and his speech was confused and garbled. Sarah pushes the call button for the nurse. The nurse comes into the room expecting to find a simple request, but finds that John is in trouble. She promptly asks Sarah to take the children and step out of the room, and she yells for another nurse to page John's doctor. The physician quickly arrives to examine John as Sarah tries to get answers from the staff at the nursing station. They were reluctant to give out information as the doctor had not relayed his findings to them. The children are scared, and Sarah is showing signs of worry and stress. The specialist is examining John when suddenly John begins to show signs of hemorrhage. His vital signs are deteriorating. Sarah is demanding answers. The physician begins calling out orders for a type and cross for 4 units. I want red cells, FFP platelets, CBC, electrolytes, a CT of the head, and of course I want all of those stat. The nurse draws the samples from John for the stat orders, as this is what they do on most of the floors in this hospital, and sends them on to the blood bank in the laboratory. The situation with John goes from what appeared to be a successful recovery to a very grave situation. The scene is frantic, it's rushed, everyone is worried that they're going to lose John with his wife and children watching. John's wife is told she might want to send the children to stay with a friend, and she might want to notify John's parents of the situation and the change in his condition. In the meantime, in the blood bank, they have received the orders for the blood, FFP, and platelets, only to discover that the sample sent down to the blood bank is improperly labeled. The blood bank cannot be absolutely sure the specimen they received is on John, or at least this John, because there is another patient in the hospital with the same name. The label on the tube was obviously not made from John's identification band, which is the policy in this facility for sample labeling. The blood bank has no option but to reject the sample and ask for a redraw. This is especially true as there is another John Taylor, as I mentioned previously. The blood bank calls the nursing unit to ask for the redraw. The nurse that had collected the sample was very upset as she knows it will add precious moments to John's treatment. She tries to get the blood bank to accept the sample. They explain they cannot accept it while going over the proper procedure for sample acceptance. The doctor calls out to Sally, the nurse, "How long will it be for the type and cross and platelets we need to get him into surgery? Where's the blood?" Sally hangs up the phone, prepares to redraw the sample. The doctor is pacing. The family is horrified at John's deteriorating condition. The blood bank staff is checking every few minutes at the pneumatic tube station to see if the new sample has arrived for testing. Finally, the blood bank receives the sample and they begin working as fast as they can. The sample is spinning in the centrifuge when the phone rings, and it's Nurse Sally. "The doctor's asking about the blood. How long will it be?" "What do you mean it will take 45 minutes? I redrew the blood and sent it to you right away." "What's taking so long?" "The doctor's asking about the blood." Suddenly, the doctor grabs the phone. "Where's the blood? I need it now." "How long is it going to be?" "This man's critical. I need blood now." The doctor's talking to the blood bank in a slightly raised voice, but the blood bank staff already knows the situation is critical. The staff tries to explain the delays, what they were, when suddenly they hear the nurse yell for the physician, "You better come quick." Sarah tries to get into the room but is not permitted to enter. She's demanding to talk to the doctors or John's nurse. Okay, so now the stage is set. This example is life in the hospital, in the blood bank, in a dynamic situation. And it goes on multiple times a day throughout many countries in the world and in the United States. Two roles that are critical yet very different, but all working for the same patient outcome. What about this situation? How do you think the parties are feeling? Well, what we have is you have the nursing staff who are getting orders from the physician, who are feeling very tense because they know John's situation is deteriorating. You have the family who's demanding answers. You have the laboratory and blood bank who's having to reject a specimen and trying to explain where they're coming from with that, because everyone knows that time is critical with this patient and care needs to be given. But yet, they all have to explain or do what is to be followed in their policies and procedures. But the thinking is quite different. So the point here is everyone has a job to perform, but everyone knows that the patient is at the center here. So healthcare professions do view situations differently, but the main objective is identical, and that's providing the best patient care possible. So my objectives are to look at different models of learning, because I think this has a huge impact in the difference between laboratory and nursing professions. I'd like to talk about identifying barriers to communication between the two professions and explore some strategies that we have found work really well to build strong positive relationships between your laboratory and your nursing staff. It's time to break the barrier down of we and they. It's time to break the door down so that nursing and lab work together to care for the patient and understand each other. So let's look at the premise that professions work from. The laboratory profession obviously is dealing with a medical diagnosis, education from and about scientific findings, and I always think of the laboratory as kind of the scientist, the researchers as finding answers for the physician, which is quite different than what the premise the nurses work from. They're dealing with a patient care plan. And you know, when I went through nursing school, I learned that there was such a thing as a nursing diagnosis, and now they've kind of converted that terminology into newer terminology of the patient care plan. But there's many, many different things. And if you had a patient with anemia, for example, that patient might be high risk for falls that are secondary to their anemic state. And so for the nurse taking care of that patient, on her care plan was to make sure the call light is there, that the bedside commode is within reach, that the handrails are up, that they have instructed the patient what to do if they need help. Where in the laboratory, they're looking at a medical diagnosis, not a nursing diagnosis or care plan. Nurses do a lot of education about disease states and recovery of those states with the patient and the family. And they are basically the eyes and ears of the physician when the physician isn't there. You know, in your large medical centers, you have residents and physicians around all the time, but in small rural hospitals, that's not the case. And so the nurse is the one that's examining that patient and relaying information back to the physician. So when things aren't going well, they become very, very tense, you know, and sometimes emotions get in the way of the way people communicate. So I always like to ask, why did you choose the laboratory profession? And what I hear most often is, I want to help other people. And I think any of us working in the laboratory profession or the nursing profession, that is one of our goals. So there might be multiple reasons why. Desire to help others, job availability. Usually there's jobs available in healthcare setting. You I hope, love science, or you wouldn't be working in this profession. It's challenging. It's changing all the time. And sometimes it's personal as well as professional goals to go into the fields. So with the commonalities that we have in both professions, let's look at the differences now. I find that laboratorians prefer less patient contact. That's why they're not nurses. You know, they don't want to be there with the bedpans and the emesis basins and all of that. You know, they want to help others, but they want to do it from a distance. Distance interaction with physicians. I think blood bank probably interacts very close with physicians compared to other departments of the laboratory. You know, laboratory professions are going to deal with patient testing. And again, finding answers for the physician and diagnosis and helping the physician treat patients. A nurse obviously wants patient contact, or they wouldn't be a nurse. They like interacting with the physician and looking at the whole care plan. And they like to treat patients as a whole. So what that means is not just based on laboratory data, which sometimes they don't understand laboratory data to the extent that laboratorians do, obviously. But they will also look at what needs do they have at home? What are they going to need when they get home? What education do I need to give them? And so it's a holistic approach. And they enjoy interaction with family and making a difference in patient care. So while they're on the front lines, laboratory obviously is not. Some of this will be a little redundant, so I'll go through it very quickly. You know, accurate tests, diagnosis, again, best patient care through laboratory testing is the technologist, and then providing care. And, you know, one of the things nurses want to prevent is relapse and readmission, because usually when patients come back to the hospital with a relapse and have to be readmitted, they're a lot sicker when they come back the second time than they were the first time. And so part of their goal is to teach them how to do well and do the daily activities of living when they do go home and take care of themselves so they don't have a readmission and come back. So now that we've established we're all seeking the same thing to help the patient, why do we have this disconnect between the departments? And I think this is where we'll get into that. In the laboratory approach is little or no flexibility in testing. I think you all would agree. If you don't follow the standard operating procedure and you add your drops in the wrong sequence, your test results will be impacted, and therefore you're not providing good patient care. So our staff are expected to follow the standard operating procedure exactly. It's mostly science, less art. I think there's an art to doing phlebotomy. That's the one area where I think it's a little more artsy, if you will, compared to in that there's just a knack for being a great phlebotomist. Laboratories tend to be a lot more regulated than nursing. You know, nursing has Joint Commission or whatever their regulatory accreditation is. If you're in a critical care area or trauma, you might have a special certification, but pretty much Joint Commission is all you see. And we know that when we're in the laboratory, you know, a blood bank may be under AABB and CAP and FDA and multiple regulatory agencies coming in and scrutinizing them. And so, you know, we're just taught you do things the way you're supposed to do them and you don't deviate. And laboratorians are very critical when they're thinking. You know, I've often been told that as a manager, you should ask your staff to try to be creative. But that's a really difficult thing. How can you ask them to be creative in an environment where they can't do anything unless you've tested it in a simulated? So I always say, you know, I want your ideas, but let us know what they are so that we can test them in a simulated environment so we don't hurt anyone. A nurse, however, You know, when I talked about the care plan, that nurse can change the order and the steps of patient care. So it's a practice where laboratory science is, it might be a practice for the pathologist, but for your everyday laboratorian, it's really not a practice. So there's not that flexibility. But in nursing, there is that flexibility. And I always share the story when I was a nursing student and I was in dosage calculations and I was taking care of patients, and a physician ordered 600 milligrams of Tylenol for the patient that I was taking care of. So I go to the med room, and you need to know that I was a laboratorian before I was a nurse. And so, you know, in the lab, we only take blood and do what the physician has ordered. You know, we don't do extra without permission, and we don't, you know, take things from patients that we're not allowed to take from. So anyway, I go into the med room and I go to pull the 600 milligrams of Tylenol. And what do I discover? I discover Tylenol comes in a 625 milligram tablet. And I just stressed, trying to figure out how I was going to cut off 25 milligrams off that pill so that I gave that patient exactly what the physician ordered, which was 600 milligrams of Tylenol. Now, what I learned that day is that in the practice of nursing, it's okay to give 625 milligrams to an order of 600, because the extra 25 milligrams is not going to hurt them. Now, that might not be the case in all drugs. Digoxin, you really should be giving exactly what's ordered. But in this case, I was fine to just pass the medication. That was really difficult for me because I was never allowed to have that flexibility. Okay, so another example would be when I was doing home health hospice care. I would go out, and I had a patient that lived 20 some miles from my home base. And when you're in home health hospice, you tend to have a whole storeroom in the trunk of your car. And so I was out doing a dressing change, and you know, I removed the dressing and I'm digging in my bag to pull out the new sterile dressing I needed to put on, and realized I didn't have the exact dressing that I should have had. Well, what am I going to do? Am I going to get in my car and drive 20 miles back while the patient's laying there, you know, or, you know, I'm not going to put the old dressing on. So no, I was able to improvise. I found something that was similar, that would do, that was sterile, that would not hurt the patient, and that's what I used. And then the next time, the next person or myself, if I went out, would bring the correct dressing that matched the one that he had been having before. Didn't hurt the patient, but I had that flexibility to change that. So if you think about that, maybe you can see how nurses have a really difficult time understanding why the laboratory is always so rigid. They feel they know their patient. Now, I'm not agreeing that that's a smart thing to think you know your patient, because it's not. It really isn't, because I can cite example after example of where we assume we know who our patients are and we didn't check identification and we find out they're not who we think they are, especially people that are getting in my age bracket where you have gray hair and, you know, your skin is wrinkly and people start kind of resembling other people. So a nurse should never really make that assumption. But, you know, when I was in ICU, I had the same vent patient for 42 straight days. And, you know, for 42 shifts, I should say, not straight days, but shifts, when you have taken care of the same patient that many days in a row, you kind of feel like you know who they are. But I didn't deviate, and I still checked that armband. So medication pass is another area where there's flexibility, and I'm not sure that laboratorians know that. And I always use this example to demonstrate how peak and trough levels might be compromised in a nurse's brain without them really thinking they're compromising a specimen. So for example, when you go to do a medication pass, if you have 9 o'clock meds, if I have 6 patients I'm taking care of, or sometimes even more on a med-surg unit, I can't be in 6 rooms at the same time passing a medication. So in hospitals, they allow you to pass meds 30 minutes before and 30 minutes after the time that a medication is due. So a 9 o'clock med, I have from 8:30 to 9:30. So I have a whole hour. So if I take that concept and go, oh, gosh, you know, I have an extra 30 minutes to get that peak or trough gentamicin level, you know, I might take a nursing practice and apply it to a laboratory test. and mess up the drawing sequence of a test. And I can see how that can happen from a nursing perspective because they're not in the mindset of the laboratory test is 45 minutes for peak after an IM and 30 minutes after IV on gentamicin. And so we think differently. So therefore, I think we don't understand each other all of the time. And we're going to talk about ways to get around that. So again, I think that nursing, they can follow SOPs, and sometimes hospitals are really lack in the nursing profession of having standardized operating procedures. I think they're getting better about this. There's a lot of changes that have taken place, and I think they are trying to say that if you have this dressing change, or you have this, or you have this procedure, that procedure you're doing with your patient, they're standardizing and bringing those in. But not all places do that, and in the past, many places didn't do that. So if I'm Sally the nurse and I learned to check a patient one way, let's say a residual on a tube feed, I might have learned to do it this way. And the nurse next to me might have gone to a different nursing school that did it another way. Both are acceptable practice, but one usually is a little bit better than the other. But if the hospital doesn't mandate which one you do, the nurse actually has the freedom to pick which one they do. And like I say, I think this is changing, but they still have not made the strides forward like we have, with the way laboratory testing is regulated in that respect. Because again, I go back that it is a practice in that. So I think that it's really difficult when we're rigid and say specimen has to be redrawn, and they go, but I drew it myself, I know who the patient is, and I know all of you out there have experienced this conversation with nursing staff. And so you just have to be very firm, but give them an explanation as to why you have to be rigid. That it's patient safety, that your regulatory agency says you have to do it this way. You cannot deviate. It's your policy. And, they'll learn and they'll come on board with you. So again, nursing tends to be less regulated, or the hospital in general, in comparison to laboratory medicine. And again, as I demonstrated with my dressing change in that, I can be creative and abstract in approach. I mean, it's amazing some of the things I rigged up to be able to get through patient care because I didn't have what I needed in the trunk of my car. Okay, I want to talk a little bit about understanding each other during crisis because, this is a time when everybody's emotions. So John today, he's getting into trouble. Everyone's emotions are running high. The laboratory's waiting on a new specimen. They're pacing the floor because they know, and once in a while I'll have someone say, well, you could give emergency release blood. And yes, that is true. But for my story, I wanted to not do that. But you have to have, during crisis, I think everybody's emotions are involved a bit, but you have to give accurate and clear communication. So I like to stress this with my staff because, if you don't have all of the information you need, before you make a call from the laboratory up to the nursing floor, and vice versa, think about all the questions you want to ask before you make the call. So, if you call up and ask a question and then you hang up and you went, oh darn, I meant to ask this, and you turn around and you call up and ask that question, what have you done? You've just interrupted the person on the other end of the phone multiple times. They can't get their work done. And the same, we feel it all the time. We'll get, when's the blood going to be ready? 5 minutes later. We'll tell them 20 minutes. 5 minutes later, phone rings. When's the blood going to be ready? So I always tell my staff, make sure if you get a call, go to the person that's working on that patient and get a realistic, accurate timeline. Because if you tell that nurse that you're going to have that blood in 10 minutes, they're going to be on the phone to you in 9.5 minutes asking if the blood's ready. And if you have to tell them that it's going to be another 10 minutes, what have you just done? You have just destroyed the reputation of the department because now they will not believe that your time is accurate. Now, you might have had something unexpected come up, but you tell them that. I'm sorry, I thought we were going to have it done. Now we're seeing a reaction that we didn't expect, and we're going to have to do some further testing. They should understand that. But don't just answer the phone and give an automatic 10 minutes, and then they call back, oh, well, you didn't bother to check, and now it really wasn't 10 minutes, it was 20. Because you have to keep a credibility going for your department. And we all know from our experiences that what do people remember? They don't remember all the good you've done. They remember that bad experience when they needed something and you couldn't provide because of a delayed time or something. So get all the facts you need, get to the point. And I'm bad about that. I like to talk. You probably hadn't figured that out yet. But I like to talk, and I have a tendency to say a lot more than I need to say to get to the point. So try to be succinct and ask exactly what you need and get to the point and get off the phone. And I know as laboratorians, like I said, when people are calling down, you just want to say to them, if you would stop calling me, I could get this procedure done. But every time you take me, and there are times when I've had my staff do that, every time you pull me away. And recently, we actually had an experience like that where the doctor was calling down from the OR and calling, and then finally, it must have dawned on them because my person was being really polite, and they just stopped and said, I bet you could get it done if I stopped bugging you. And it was like, yes, that would help. But people will realize it after a point. But if you know it to begin with, it just saves everyone a lot of hassle and time. And the next one, I always tell my staff, if you don't know the answer, that's okay. But don't fake your way through. Don't try to pull the wool over someone's eyes. If you don't know the answer, ask someone who does. And one of the ways to handle that is, I don't know, but I will find that answer out from you. Would you like to hold, or would you like for me to call you back? And leave the option up to them. And that way you can go find out what you need to find and get back to them. If they choose to hold, great. If they want you to call them back, that's fine. But you've given them that choice. And as always, we're going to put the patient at the center stage. So I talk about cohesive patient care. So if you look at this diagram, which I should update sometime, this is just a small representation of all of the departments within a hospital that have to take care of the patient. So I would ask you to think about where the patient is in this picture.
Most of the center.
Right, and it is the center. And sometimes I will have people say, well, they're here, they're there. But no, the patient should always be the hub of the wheel. And all of these departments around them are taking care of the patient. My point with this slide, and sometimes I get raised eyebrows about this, is that I personally feel that not a single entity up here is any more important than another entity up here. So whether you're a nurse, whether you're a physician, the laboratory, respiratory, the housekeepers, the facilities, administration, everyone has an equal part in providing excellent patient care. Because what happens if one spoke on that wheel or one pie on that wheel does not do their job correctly? So, if the housekeepers let the trash overrun to the point where it's falling all over the floor and the patient is actually, becoming exposed and visitors are exposed to whatever, that's not providing good patient care. So if you think about this as a wheel that's rolling along, we have cohesive patient care and the patient's having a great experience and being taken care of, that's great. But if one part of that does not perform their job as they should, imagine that wheel trying to roll along. It starts getting bumpy. So now if you've got, I think that if I go back, that one was facilities, and now you've got the housekeepers who aren't emptying the trash. Facilities isn't fixing the call button. Nursing's never around when you ring the call button. Suddenly you have all these parts and pieces that aren't performing their job as well as they should. And imagine what that wheel tries to roll like, and you have fragmented patient care. So I was giving this to a group of nursing. Well, I guess I could go to the next slide. And I asked them where they felt, or I ask you, where do you feel the nurses think they are in this wheel of patient care? And the most common answer I get is they think they're in the middle. They think they're center stage. And of course, it's usually laboratorians that I'm talking with, but that is not where the nurses felt they were. And, I have to admit, when I was giving this talk to a bunch of nursing service directors, they were like, their response to me was, we are the rim of the wheel. And my gut reaction was, really? I don't think so. But then I took a step back and I thought about it, the role of a nurse on the floor. And they're the patient advocate. So your patient's in the middle, and that nurse is really that patient's advocate. And they're relaying information to the physician. They're checking on lab orders. They're scheduling respiratory therapy. It may not be the actual nurse, but it's someone in nursing services that's working with the nurse, taking care of the patient to do this. You know, someone under them is probably going to call housekeeping and say, trash is overflowing. I need it in room 101. And facilities, can you fix this? The lights out in the bathroom. And if the family's upset, the nurse is going to call administration and make arrangements for the family, go talk to administration, etc. So they really do kind of surround all the functionality and act as the patient advocate to hold all of this together. So when I stepped back, I went, okay, I was doing a little bit of we and they there that I shouldn't have been doing. And they're right. I had to give them credit for that. When things get tense, I always tell my staff, you need to be patient and calm in all situations. But above all else, be courteous and professional. There's no reason not to be professional. And it's difficult, I think, for human beings sometimes to do this because your emotions get involved. And, you know, sometimes people want to yell at you, telling you that your patient, you know, they need the result. And if you can't give them the result, there's going to be bad harm, you know, and all of this. So I always tell my staff, you need to take a moment. So all of you laboratorians out there, put yourself in Sally's shoes today as the nurse who's got the doctor wanting orders and she's family is asking for answers and she's watching this patient deteriorate. It's very tough to be in those shoes. But it's also tough in the laboratory when you understand the implication as well. So always put yourself in the other person's shoes. And if the other person is unreasonable, it's perfectly acceptable to ask to speak to someone who is reasonable. And people go, well, who would that be? And I always tell my staff, it's your charge nurse. Every floor has a charge nurse. And if you can't get anywhere, sometimes people's emotions are so involved that they just aren't hearing you. And you need to get past that. So if you're trying to relay important information and the person is just so involved that they cannot hear what you're telling them, then ask to speak to the charge nurse. And that's perfectly fine to do that. And I had an experience very young in my career, not with nursing, but it just drove home a good point. When I was right out of school and on my first job, I did nights and evenings. And one night, it was years ago, I'm dating myself, when you had to soak the apertures on a Coulter counter. And I was on the backup instrument and a hemoglobinometer and a spun crit. Okay, so the hemoglobinometer breaks, so I can't get a hemoglobin. And of course, there's an OB patient that's going bad, and the physician called down wanting the H&H, and I'm trying to explain to him I can't give him a hemoglobin, I can only give him a hematocrit. And I mean, he did. He literally called me names that I had never heard of before. I mean, just cursing, and I'm just shaking in my boots. And so I get through it, and you know, I'm thinking, well, take the crit, divide by 3. It's approximate. That's good enough. And I didn't understand why he was so upset. So we got through that crisis, and the next day I was switching from a night shift to an evening shift, and I came in, and I'm back in the chemistry department, and someone from up front comes back and says, well, Dr. So-and-so's up front, and he wants to see you. And it was the same physician. And I'm like, oh my gosh, what am I going to do? Here we go again. And I went up front, and he introduces himself to me, and he says, you know, I came down because I wanted to personally apologize to you for my inappropriate behavior. He said, I thought my patient was dying. I thought they were going to hemorrhage to death. And OB patients can. I mean, you know, it's a very serious thing. And he said, I was so tense that whoever was on the phone, the next person was just going to get an earful, because that's what I had to do to relieve my stress so that I could get back on track with keeping my mind around what I needed to do for my patient. And he said, I just really feel badly that you were the one that was on the receiving end of that, so I hope you'll accept my apology. And I have to admit, I had a lot of respect for that physician from that point on, because for one thing, he could admit he was a jerk. He admitted he was unprofessional. So I tell my staff, don't put yourself in that position where you have to go back and apologize for being unprofessional. Try to keep the emotions down, get through the crisis. However, I, as your manager or the person who is your supervisor, needs an email when you've been treated unprofessionally. Get through the crisis at hand, stay professional on your end, but let me know, because my job is to go back to their nurse manager and say, we had an incident last night. I think emotions were involved. but could you please talk to your person because they really handled the situation very unprofessionally. And then it's our jobs to, and I feel I have a good relationship with the nurse managers, and I can go say and lay it on the line, that my person really had angst over this and was not treated appropriately. And they'll respond. So just keep that in mind. But it's always okay to ask to talk to someone who's reasonable. Sometimes bridging that gap can be a really tough climb. This is one of the Cottonwood Canyons here in Salt Lake in the fall with the aspen trees. But that mountain's pretty tough to climb, and it doesn't always feel natural to go up that mountain to bridge the gap. So we're going to talk about that. So shadowing the other profession has been somewhat successful for us, very successful with one particular department. They thought that, we don't like to have hemolyzed specimens, and we'd get mislabels and we'd reject them, and they just could not understand. And the nurses thought we were making up the fact it was hemolyzed because we didn't want to do the testing. And I'm like, really? So we started having them come down and shadow us and follow a specimen from the beginning all the way through till the test was reported out. That did a lot of things for us. One, they saw the mislabeled rack, realized, oh my gosh, yeah. They watched a test and realized the timelines that it takes to do a type and screen. In their mind, we all know that 10 minutes can seem like an hour. But in their mind, they had no idea of what was involved behind the closed doors, behind the biohazard signs of the laboratory. So I encourage you to do some shadowing with other professions and bring them down, especially the ones you're having the most difficulty with. Have them come down and actually spend some time with your staff. And ask to do the same in reverse. Read about the profession, their roles, their jobs, their education. Sitting with departments during lunch breaks, meetings, and in-service education, I have found this really helpful, and I encourage my staff to do this, but it's a very unnatural thing to do. You go to the hospital cafeteria, and what do you see? You see radiology over here, and you see nurses over here, and the labs over here, and people just don't tend to mingle. Now, I think smaller community hospitals on the off shifts do this very well because they have to for survival. They rely on each other. The numbers are low at night. They don't have excess staff. But, I've walked up to complete strangers and said, do you mind if I join you? And no one's ever said, no, we do mind, get out. They're very receptive. And then pretty soon it leads to a conversation. Well, where do you work? Well, I'm in the lab. Well, what do you do down there exactly? I've never understood. What goes on behind. And then you start this conversation. But what's happening when you do that is more than just insignificant conversation. What you're doing is suddenly they're putting a name to a face. And then if they have a problem, they're going to remember that conversation, and maybe they'll call you and say, I need to talk to someone down there. I'm not sure who it is. And you start building those relationships. And I was giving this talk in California, and there was a medical technologist that always drove to work. And when the gas crunch hit, she started carpooling. Well, what she would do is she would drive to the lot, and then the hospital had a bus that would take them on into the hospital, a lot like the University of Utah does with their ozone bus, where they go to an external lot and then they drive in, and it saves on gas and when you don't have parking space. Well, what she discovered was at the time she was coming into work, there were a lot of nurses on that bus. So they just started having a conversation. And then pretty soon it just, the conversation got deeper, and that person would remember that person. And one was a nurse manager, and she would call down when she had issues, finding out who to talk to. And then as the gas crunch went on and economic times hit even harder times, she found out that on that bus there were 3 of them that lived in the same neighborhood. And so then they started carpooling together. And then suddenly what started out as just something very casual turned into a really great, not only personal relationship, but working relationship. And she felt like it really did a lot to bridge the gap between professions, because then they kind of branched out and got to know the other managers in the laboratory and things like that. I had another hospital that always had a potluck in the lab once a month. And they reached the point where they would invite a different nursing unit to come down and join them for food. And then they would just converse over lunches. And I mean, little things like that aren't difficult to do, but it's amazing the relationships and the gap bridging that happens out of all of that. So don't be afraid to invite the other profession to your department. Set up exchange programs between laboratory staff and nursing staff. And I'm really a big proponent of this. And as I said, that one department, it was the obstetrical department. They started mandating that all their new employees come down and spend an hour. Critical care interns would come down and spend an hour and just follow a specimen through. And this last year, we started sending our blood bankers up to surgery to watch a surgery. And so they were able to go up and watch a cardiac surgery. It was usually cardiac because they really are very interested in seeing the heart. But it was a really neat experience for them. And now they're going up and spending an hour. It's always on the shift that they were, not in surgery, but the other experience in the critical care areas, and especially the surgical ICU. We have a very big active surgical ICU. And the staff are going up and shadowing for at least an hour on the shift they work. And I think it's important for them to try to do this on the shift they work, because suddenly they're able to put a name to, or a face to the name that they talk with on the phone. They have interactions all the time on the phone with these people, but never get to see them. And then, just to build that relationship. And it's, so far the feedback has been great from both sides. They really appreciate being able to show them around and have them see what happens up on the patient floor. Sharing education ideas, do some joint ventures in education. I find that that's helpful. Maybe there's something going on in the hospital that involves both departments, and get together and come up with an education plan. And I always believe in letting the other profession, regardless of whether it's nursing or whatever, let them have your ear. Be a good listener. Listen to their concerns. Listen to what their needs are. And then you know what direction to go. And it should be vice versa. And I think that, I've had people when I've given this talk say, why is it always lab that has to venture out, and invite them? But don't let that stop you. It has to start somewhere. So let's be the people that start it, And another thing is, I think sometimes laboratorians tend to sell themselves short in their profession. They don't promote their profession a lot. And so, I believe this week is National Nurses Week, and it's plastered everywhere, and we have National Laboratory Week. But I think maybe, sometimes we need to do a little more than a tour of the lab and cookies and punch, but actually have them come and spend some time. But time is precious and it's difficult. You have to develop trust with your nursing leadership. You want to be a consultant. You want to have, and I tell my staff, it doesn't have to be me that is that consultant. Your med techs, your staff in your laboratories are the experts in laboratory medicine. So they need to build that relationship so that they're recognized as that. And then when someone has a question, they'll go, I know who to call. They will find the answer, or I know how to get this question answered. And those relationships will just come. I like to find out when nursing management meets. And so, like the critical care nurses meet once a month. And I used to go every month for just 5 minutes, but I've kind of toned that back and now go when I feel I need to. But all I take is 5 minutes of their meeting, and I just go. And, my main purpose of going is just to find out how we're doing. How's the blood bank doing? Are we meeting your needs? And if I ever go to any meetings by invitation, that's one of the first things or the last thing. Somewhere during that meeting time, I will always ask, is my department meeting your needs? And if they're not, I need to know what the issues are. And so I was invited to go to the OR. The HCAs have a meeting separate from the nursing staff in the OR, and these are the people that'll run down and pick up blood or come down and get the coolers of blood before OR and whatever. But anyway, I was invited to come to their staff meeting, and I always take a notepad. And we got toward the end of their staff meeting, and much to my surprise, they had a list of about 10 things they wanted me to fix in my department. And so I'm sitting there taking notes, and there were a couple of them I immediately said, no, can't happen, won't happen. It's a regulatory issue. It's a dead issue. I can't change it. Sorry. But I took notes of the other things. There were about, I think we ended up with about between 7 and 8 things on my list. And we were in the middle of a construction project and remodeling the whole blood bank. And one of them was when they sign out blood, we had these temporary counters. Well, place for them to lay the blood out when they went to do the readback. They were having to try to handle this in their hands. And they said, it'd be really nice if you could just put a shelf on the back of that so that we had a place to lay the units when we're doing the readback. And then it was like, well, you scan our badge in your computer system when we pick up blood, but your people cover their badge up with their lab coat, so we don't even see what their name is. Simple, So I was able in about 2 months or less fixing all but one of those 7 or 8 things on their list. So they were little things, but it was things that just really made a difference in their everyday life. And, they were so grateful that we had done that. But I didn't know that at the time, and I kept communicating with the nurse manager about, we fixed this and we fixed that. So anyway, about 3 months went by and Julie calls me up one afternoon, Cindy, the HCAs want you to come to their staff meeting again. Are you available on such and such a day? And I went, oh, what can they want now? Because I felt like, okay, I don't know what else they could want, but I'll go. So I'm going and I'm patiently waiting, and we got toward the end of the meeting, and she said, oh, I've got Cindy. You all wanted her to come to your staff meeting. And so I got up and said, well, I'm here. Are we taking care of your needs? Is there anything you need? And they all stood up and applauded. They were so happy that we listened to what their concerns were and fixed as many of them as we can that made a difference in their everyday life. So with that said, sometimes it's little things, but they make such a huge difference. So don't overlook those. You want to always be educating, again, when you're consulted about regulations, practice, interpretation of laboratory values. Nursing has changed a lot, and I think they're spending more time in nursing schools regarding laboratory results and interpretations and things. But when I went through, it was not very much time spent on that. I would look them up on my patient, but as far as actual time that was spent, I was amazed at how little time is spent. They learned coag values, a CBC, a basic metabolic, and that was about the extent of it. It was not very in-depth. And so suddenly I realized, wow, now I know why they don't realize what we do. You want to always make your expectations and concerns known to nursing upper management. So if you're having issues with the nursing department as a lab, you need to call up and just talk to the nurse manager. And it's really good to round with nursing units, and I don't know whether you're familiar with some of the Studer terms of managing up and rounding, but I round with about 3 nursing units a month. It's just a simple either email. Sometimes I get better response by email because everyone's so busy, but I'll just say, gosh, those same questions. How are we doing? Are there any issues? I offer education on blood administration and patient identification. If you want me to come to your staff meetings or any of your education meetings, I'm willing to do that. Different things like that, and just to get a pulse of how you're doing. Our phlebotomy unit actually rounds with patients on how the patient feels the phlebotomist is doing. Did they state their name? Were they polite? Those types of things. And then managing up, and I'll give you an example of managing up in a minute. And then, of course, I'm a firm believer of reward and recognition. You've probably figured that out, but maybe not. And I had an issue going on with one of my nursing units, and I was doing audits, and the audits weren't what I wanted them to be. And I, was going back and re-auditing, and I was working very closely with the nurse manager, and they really cleaned it up. And they had no more deficiencies for on my audits for about 6 months. They just really turned it around. And so I went to their staff meeting with chocolate just to say thank you. People relate to food, and it was just like, here's a little something, thank you very much. And then if we ever have a deviation, if we have a deviation that goes out and somebody on the nursing end has just done a fantastic job of picking up on that deviation, it's not uncommon for me to just send a pair of movie tickets to that nurse and say, thank you. We really appreciate the fact that you were doing your job and caught this deviation. You want to be an educator of your laboratory profession, share best practices. Don't spend time reinventing the wheel. You know, it's really good. And get involved. Now, when I've given this talk before, people go, how do you find time to do this? You know, it takes time, I will admit. But I find that I like to get my whole staff involved. So I'm a bigger transfusion service and a bigger hospital, so it's a little easier for me than it is a smaller hospital. But if you're a small facility, just start slowly and take one little thing at a time. And it will be beneficial to you over time. So you don't have to jump in, you know, all at once and do it all, but just start slowly. I've already talked about this, you know, staff, students, friendly, converse, interact with your staff. Can I assist you? This is an example of a rounding log. Is my department meeting your needs? Are there any recent issues that have occurred with the interactions with my department? Is there anything we can do better in our area? Is our communication satisfactory? Or are there needed improvements? And if there are, let us know what they are, and thank you for your time. And you can just make little cards and drop them off on the nursing units, and the people that are interacting with the department can fill them out and then return them. And you can kind of see what the issues might be. That's one way. Managing up, when laboratory staff compliments nursing staff, I always let, you know, if my staff say, hey, you know, I talked to so-and-so up on the floor and they really took care of what I needed and got a hold of the doctor or whatever, you know, I relay that back to the nurse manager. So that nurse manager can go praise that employee. And if I do patient audits, again, managing up, another thing I do is, so we do patient armband checks, and so one day I'm doing a patient audit, and the patient was extremely upset that his middle name was incorrect on his ID band. And he just, you know, when you're a patient, you have no control. And you're feeling very vulnerable. And he had wanted his name changed. And it's the policy in our facility that if they're receiving blood products, we don't change their name till after, because we know that the band that's on, even if the middle name isn't correct, the blood in the tube at the time it was collected is from that patient. So we wait until they're out of crisis, and then they can update the name. And he said, I've asked 3 times and they haven't changed this. And I said, well, did anyone explain to you the hospital policy? And I have to fault the nurse, because the nurse just said no and didn't explain the hospital policy of why they didn't change it. But in managing up, what I did is at the end of my conversation with him and putting him a little bit more at ease once he found out it was policy and they were doing exactly what they should have been, I said, you do know that you are on a fantastic floor. The nurses here are really good at what they do. They give excellent patient care. Now, by all means, don't lie. If you really feel that the floor isn't top-notch, don't say it is. But this floor is top-notch and was, you know, great nursing staff and great patient care. What did that do for that patient? It put them at a little bit more ease. This is an example of the phlebotomy that they do. Did the phlebotomist draw your blood, introduce themselves? Do you remember their name? How did they do and why? And is there anything they could do better? Again, I try to compliment. One of the things I do is I send thank you notes to the nursing staff. That catch deviation, as I said, sometimes other rewards. But I also try to thank my employees in front of other employees, because it really feels good. And I got a thank you note one day at home in the mail from one of the hospital administrators, and it was kind of cool to share that, opening that up and reading that with my husband there. Turnaround times, it's all about proof, so make sure you act on those when you have complaints. Act quickly, delve into the issues, and try to respond as quickly as possible. And, you know, the third item down, you know, quality teams. I've served on several quality teams with the blood bank and just working out workflows with patient care areas, and it's not always me. Sometimes I decide, that's a good project for an employee to be involved in a hospital quality team. So get your staff out there as well, because that just helps them build relations. Become a consultant, become a valuable resource. You want to keep yourself current on what's happening in your own institution. Make sure that you know what's going on. Reward the other profession for wins. Reward your staff, students, when they work well with other departments. This is what it looks like when it's serene to bridge that gap. A lot different than climbing that mountain. And we're all here to provide the best patient care, and we're all part of the same professional team.